All right, I'm going to try to get us back on track, but it has been so good, so fruitful. Maria is going to provide us a brief overview of what we're about to do, which is to provide and present the recommendations from the subcommittees. Maria?
Thank you. And this is just a quick overview of how the process works and what's been going on behind the scenes. So essentially, the Advisory Council has 4 subcommittees who meet on a monthly basis, and they've been working really hard to develop recommendations to bring forth today. And as part of that, they're going to present on their recommendations, and then there'll be voting and adoption, hopefully, of those recommendations. But just wanted to call out that as part of that process, federal members do not vote, but do provide technical support as non-federal members really, develop those recommendations. So just want to have that in the background as we move forward.
Thank you, and I just wanted to say a big thank you to all of the subcommittee chairs. I don't think they realized what they were all getting into because we had to meet at an expedited pace. It was a rapid pace, and there were a lot of meetings that we had to conduct. So starting with Dr. Randy Bateman, who was the first one to kick us off and get us started and really jumped in and really set the precedence for all the other subcommittees. So everybody quickly got on track. So wanted to introduce Dr. Bateman and also say thank you. Thank you so much.
Very welcome. I'm delighted to present our recommendations for the research subcommittee. If we can go to the next slide, please. Here are the research subcommittee members. You can see the non-federal members listed as well as our federal members. We had multiple meetings to review the research recommendations, lots of lively discussion, brainstorming, and impact, and we think we have some fantastic recommendations that the decision makers should look at carefully and implement. Let's go to the next slide. Great. So our recommendation number 1 is to ensure research directions are determined by scientific experts using evidence-based decision-making and input from people living with Alzheimer's disease and related dementias and their caregivers. Congress should increase federal research funding and investments to meet the stated NAPA goals for preventing and treating AD-ADRD. We've had a bit of discussion on that already today about what that means and how we might be able to accomplish this, including some of the magnitude that it might take. And that was the precursor in the full set of recommendations. You'll see us expand on why we need to do this. The moment is now. And that capitalizing on the investments made already are likely to yield further breakthroughs with large impacts in the health and care of people with Alzheimer's disease and support for ongoing research efforts. Recommendation number 2 is to sustain current trials and fund new long-term prevention and early intervention trials for AD-ADRD. This recommendation was provided with the impetus that an ounce of prevention is worth a pound of cure, that if we are able to identify those who are at risk, and you saw evidence today that we can, and we can intervene before people get sick, the impact, the magnitude of that impact and the clinical benefit to patients and families are likely to be much larger than we can do at the symptomatic phase of the disease. There are ongoing clinical trials through the NIH and other organizations for prevention. As these trials read out, the next trials will be reading out next year in 2027, and then in 2028. It will be critically important to be prepared, understand, and implement the effects of those trials. It will also be important to launch the next generation of prevention and treatment trials to be able to prevent the onset of Alzheimer's and related dementias. Our recommendation number 3 is shown here. This recommendation is based on the research recommendation of breakthroughs in just the past few years and the capabilities of artificial intelligence to greatly accelerate our research, both in the lab and in the clinical arena. and its ability to change what we're capable of doing, both in terms of discoveries as well as in terms of implementation. And so through the revised national plan to address Alzheimer's disease, the recommendation is that Congress and HHS should invest in the application of AI and big data to transform discoveries in AD-ADRD, mechanisms, diagnosis, treatments, and management. And finally, our recommendation number 4 is to leverage the revised national plan to address Alzheimer's disease to establish a coordinated national AD-ADRD clinical research infrastructure. Through the revised national plan to address Alzheimer's disease, currently in development, HHS and Congress should establish a coordinated national AD-ADRD clinical research infrastructure that is modeled on the highly successful National Cancer Institute system. This recommendation is being made because we are now at a stage of development and poised with the successful development of blood-based biomarkers, interventions that reverse pathology, change the course of disease, and a clinical population that needs to be treated, that on that backbone, we can now establish a highly effective and transformational prevention trial system across the national medical system. This will take an investment to build, sustain, and grow, but is likely to yield major transformative changes in how we can stop this disease in the near future.
Thank you so much, Dr. Bateman, and thank you to all of the members of the research subcommittee, both federal and non-federal. Next, we are going to go to the clinical care subcommittee recommendations, and that will be presented by John Corris. I know, John, you're online, right?
I am, Madam Chair. I am online. Can you see and hear me?
We can hear you perfectly.
Okay, great. Well, I can see myself, and I look fantastic today.
You look
so
great.
Okay, we'll jump. Well, in the interest of time, we'll jump right into it. First, I want to start off by thanking my clinical care subcommittee members. I also want to recognize the federal members that were involved. The non-federal members, the committee members, were absolutely outstanding. We had great debate, good spirited discussion, and we have some thoughtful recommendations I'd like to share with you today. Our federal members were excellent. They provided context, some guidance. They were wonderful partners in this process, so I'd like to recognize all of them and thank them. If we could go to the next slide, which I see that you're on. We have 3 recommendations. Our first recommendations is to advance best practices across AD-ADRD care continuum. Now, what that specifically means is defined in 2 points. HHS should develop a framework for continuous improvement and implementation of best practices for screening, diagnosis, delivery of care, treatment pathways, care navigation for people living with AD-ADRD and their caregivers, and provide training across all clinical roles. In the next recommendation, Congress should prioritize funding for an improved and consistent national AD-ADRD care continuum. Number 1, standardized screening through annual wellness visits and tie funding to increase screening rates and equitable access, expand workforce training, and invest in scalable models such as Project ECHO, CME, and nursing curricula. Number 3, strengthen care pathways so coordination, education, implementation, and training are standardized across all clinical roles. Item number 4, support prevention research, including vaccines, vascular health, delirium prevention, explore the ACEP Act in more detail. Address access gaps and prioritize underserved communities in screening, diagnosis, and care. And finally, tie funding to measurable outcomes, dedicate funding for national brain health initiatives. We go to the next slide. We go to recommendation number 2. Let's improve screening and diagnosis by standardizing AD-ADRD screening. Specifically, HHS should direct CMS to include standardized AD-ADRD screening in their annual wellness visits. B, Congress should provide dedicated funding and incentive structures to support education, prevention, screening initiatives, and community-based interventions, including a national Alzheimer's and brain health awareness campaign. Our final recommendation on the next slide, recommendation 3, create a CPT code education campaign for providers and healthcare systems. HHS should direct CMS to create a CPT code education campaign that targets and trains care providers and health systems. This would prioritize CPT code 99483 and include education on relevant ICD-10 CM diagnostic codes. And with that, that is the last of our recommendations. Thank you for the time.
Thank you, John, and all the members of the Clinical Care Subcommittee. And we did get a chance to see you, and you do look great. Just saying. Next, we have our Long-Term Services and Support Subcommittee, co-chaired by Christy Putnam and Kate Newkirk. And Christy, are you presenting?
We're going to tag team it.
All right, a tag team. Thank you. Thank you both so much.
So first of all, I just want to say thank you to everyone who presented today. I think we've all really learned a lot from the topics that were covered today. And the takeaway actually that Christy and I were talking about is there is so much coordination between what was covered today and then also the recommendations that are being put forth today by this committee. So it's quite wonderful to see how even the things that we've talked about kind of in our breakout sessions as committees all really connect and coordinate with one another. So with that, I just want to say also thank you so much to our non-federal members. Thank you so much to Christy for stepping in as co-chair. As I am expecting my first. And so that has been a journey in itself. Thank you so much, Christy. And then also thank you to our federal members for all of your support during our meetings. And with that, we can jump right into our recommendations, and I will hand it over to Christy.
So we had a lot of conversation in our first meeting, our organizational meeting, about really truly focusing on actionable items, things that didn't take congressional action, things that we had already available to us, because we felt like, we discussed, our federal partners brought us a great deal of information on the resources and the community partners who are available to assist with LTSS, long-term services and supports. So jumping into the recommendations, the first recommendation is strengthening dementia care navigation and leveraging federal resources that are already in existence. This includes elder care locator, aging and disability resource centers, the area agencies on aging. I won't read all of them to you, but the point is we have a lot of resources in our communities that are not accessed on a regular basis or that people simply don't know about. One of the things that I've consistently seen in the work that I do in HHS across all programs is we are resource rich but connection poor. So we really focused in on on ways that we can increase those connections and also connect across the subcommittees, because we did connect in on a couple of different things that the other subcommittees recommended as well. We can go to the next one. The second recommendation is we also focused in on CPT code 99483. There is a separate visit that Medicare covers each year that can be for the assessment and care planning for individuals who have a diagnosis. So we want to see an increase in existing Medicare dementia care planning benefits, increased use of that, and we said HHS should direct CMS to expand education and outreach to physicians, health systems, clinicians on the appropriate use, and also patients on the appropriate use of existing dementia care planning services. We believe that for LTSS purposes, this can improve care planning, it can improve our caregiver engagement, and people simply don't know how to access the resources. And so an across-the-board education campaign for all parties involved in dementia care. We can go to the third one. Lastly, we talked about the use of AI and technology, the connective technology that exists out there that can really be used, and that there are navigation platforms that exist, and there are also care coordination platforms that exist out there that are using AI to make sure that there's consistent and coordinated communication among all parties who are providing care to an individual. So our recommendation is that HHS should direct the Administration for Community Living, CMS, and other federal partners to encourage the development and use of evidence-based digital navigation tools, including the AI-enabled platforms that have been referenced quite a bit throughout this discussion today, that direct caregivers to verified local dementia resources. And again, that's that use of AI to make sure that we are connecting people to real resources that they can actually step into. There's a concern about giving a diagnosis too early. We've talked a lot about the early screening and detection. We coordinated a lot with our risk reduction. We actually met one time concurrently with our risk reduction group, and the 99483 code was discussed quite a bit because that is a mechanism for us to use for that care planning. So that is a summary of our recommendations. And thank you to everybody. Thanks, Kate, for asking me to step in and help. It was really a rich experience. I learned a lot.
I wanted to say thank you so much to Christy and to Kate and to all of the members on the subcommittee. This was a very fruitful discussion, and we did collaborate across risk reduction. You'll see risk reduction, early detection, early diagnosis kind of peppered through all of our subcommittees, which I've really loved that was echoed through all the different spaces that we were convening over. Next, we have our risk reduction subcommittee, which is our final subcommittee of the day, and the recommendations here. Dr. Jonathan Weiss is our chair. Dr. Weiss, are you on? And if he's not, I can always be the plan B. Yeah, it's okay if we're not. Okay, we'll go ahead, Maria. I can do it, yeah. So again, risk reduction was something that we really focused heavily on, being peppered throughout all of our subcommittees. It was a very rich conversation, as Christy said. Rich is the right word. A lot of time was spent thinking about the disease from this perspective. How do we have lifestyle interventions, mitigate our risk factors? What are the necessary criteria? We looked at it from a policy perspective, funding perspective, and otherwise. Wanted to thank our non-federal members and to Dr. Weiss for stepping up to be chair of this, and also to Dr. Mayo for just really providing a lot of great commentary from a health systems perspective, and then to Dr. Giles as well as a clinical perspective. And many thanks to our federal members. I think they guided us quite a bit. Special thanks, I know she's not here, to Erin Long, who spent a lot of time really giving us some fruitful things to think about. So our first recommendation is to prioritize, obviously, early detection and early diagnosis. We have asked that HHS should standardize and require the use of validated cognitive assessments during Medicare visits. And we ask that Congress should pass 2 key bipartisan bills to advance early detection. That is the ASAP Act that you heard from Rachel Conant from the Alzheimer's Association, and the Change Act that you heard from Erica. These 2 pieces of legislation are bipartisan, they are congruous, and we ask that Congress contemplate them. We've already gotten well underway, as you saw from Rachel's great slide, to see a lot of dynamic engagement on the part of the Senate and the House. So hopefully we will continue through that process. Recommendation number 2 is a launch of a national Alzheimer's education awareness campaign with a multi-sector, multi-agency approach. That's a mouthful. But we really wanted to make sure that we were very collaborative, not only with each other, but also with our agencies. So you do see a lot of collaboration on this council with our federal agencies, and you see more federal agencies than you've ever seen be a part of this really important conversation. So we're asking HHS through NIH and NIA, CDC, and CMS, your typical folks that would be engaging for a national plan or public awareness plan, launch a coordinated campaign on early detection, risk reduction, and healthy brain aging. That's not to say that there haven't been outstanding bits coming out of all of these different agencies, but wanted to see a coordinated campaign that would provide some CMS guidance on evidence-based cognitive assessments and care pathways, but also to increase public awareness of baseline screening, risk factors, opportunities for early interventions in their own lifestyle. Again, also thinking about and contemplating promoting the use of the pointer-informed multi-domain strategies, physical activity, healthy nutrition, cognitive and social engagement, and management of cardiovascular and other health conditions. And we really feel, too, that this was an expansion of how the Make America Healthy Again agenda really contemplates exercise and nutrition, and then expanding awareness of treatment options and access to appropriate clinical trials. Congress, we thought about this both from a pathway perspective and a funding perspective. So we're asking Congress to provide $7 million for that national multi-sector, multi-agency Alzheimer's Concern and Awareness campaign, and consider also primary care providers and health systems in that campaign. So recommendation 3 is to direct the FDA to continue fast-tracking more AD-ADRD trials that include pharmaceutical and non-pharmaceutical. And you've heard a lot about some of these trials today, both pharmaceutical and non-pharmaceutical approaches, while expanding the FDA's accelerated approval program and convene the U.S. Preventative Services Task Force. There we go. I was about to do the acronym, but I really wanted to spell it out for you. HHS should establish a coordinated pathway to accelerate innovation and expand access to Alzheimer's treatments and interventions. And we really feel like HHS is already doing this. So to expand on that and direct the FDA to continue their great work to fast-tracking more AD-ADRD trials. So thank you to the FDA who has been doing that, and also consider convening the USPSTF. HHS should also convene that task force to evaluate the growing evidence base for early detection and intervention and help establish clear evidence-based guidance. We're also asking HHS direct NIH, NIA, CDC, and CMS to launch a coordinated national education initiative. And this one is specifically, as I mentioned before, the other one was a public health campaign to the public. This one is to primary care providers, neurologists, and other health professionals with current evidence-based information and AD-ADRD treatments, interventions, clinical trials, and available care resources. So we're looking at this national health campaign to really target the public and also consider targeting our health system through our primary care providers and our neurologists, where we first go to get our diagnosis. And that concludes our recommendations from the Risk Reduction Subcommittee. Thank you, Maria.
Well, I already gave an overview of the role, so actually I'm going to turn it back over to you, Michelle, to officially start up the voting. And again, just a reminder, non-federal members only.
Yes. So are there any questions before we begin the voting process? Any questions from the non-federal members? Again, just want to thank our federal members and our non-federal members. And I wanted to share with the audience before we vote, we really wanted these to be substantive and be highly directive. So there's a lot more of meat there because we did spend a lot of time meeting. You can just ask all of our subcommittee members to attest to the amount of meetings, the cadence of the meetings. There was a lot of them, but we wanted to dive in, get the research, get the education, and then be very prescriptive in our direction and our recommendations. So hopefully you see that evidenced by the recommendations that you heard today. With that, I'm going to ask for our non-federal members to take up all of the recommendations. Can we do all of them at once? Yes, okay, good, yeah. And I need a motion on the floor to take up all of the recommendations for voting.
So moved.
Second.
Second.
Thank you. So we have a recommendation to vote from Dr. Mayo and a second from Christy Putnam and someone else. Thank you, General Hartzell. And a third. All right, I'll take it. All that being said, if you are a non-federal member, please say aye.
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 Any opposed? So moved. Oh, yes, we do have some folks online. My apologies. John Corris, can I get your aye?
Aye.
Thank you. Dr. Weiss?
You're welcome.
He may be off. And then I know Dr. Giles is on there as well.
Yep, aye.
Thank you, Dr. Giles. With that, our recommendations are officially approved. Thank you. Thank you to everybody for all the hard work. I got us back on track, y'all. That doesn't happen often. Okay, so congratulations to everyone, and thank you to all the members. We can take a quick break if you'd like, and then we're going to get our public comment, and then we will be done. Okay, wait a minute. I take it back.
Sorry, one second. One thing I didn't mention is that the draft rec will no longer draft. The recommendations are posted online on our NAPA website for those who want to peruse the full set of recommendations.
Thank you, Maria. And like I said, the recommendations were condensed here that you saw today, but there is a full recommendation package on the website. And I do want to say thank you to Maria. So much hard work going into all of that, especially with the National Alzheimer's Plan and everything else. So many, many thanks to ASPE and to Helen and Maria for all of their hard work, guidance, dedication, and keeping us on track. I can't thank you both enough for everything. Thank you. And with that, we'll take just a quick break, and then we'll come back for some public comments, and then we'll have our concluding remarks, and I might even get you out a little early. I don't know. Thank you.
Produced by the U.S. Department of Health and Human Services.